Dr. Vikas will be talking on double anterior, single posterior delineation technique to correct plane, dissection plane in smile. So on to you.
Good afternoon, everyone. I am on a mission here to prevent another patient undergoing lenticular misdissection in keratolenticular extraction procedure and landing up with suboptimal outcomes. So I have no financial disclosures to make. So keratolenticular extraction procedures have become increasingly popular and offer multiple advantages over flap-based procedures. But they do come with their own set of challenges. The most common being for the surgeon to face initial posterior plane dissection and cap lenticular adhesion, resulting in complicated dissection, leading to poor outcomes and headaches for the surgeon. Though multiple signs have been identified previously, but they are not easy to identify for a novice surgeon, especially during surgery for correct plane identification. Conventionally, what most surgeons do is that we want the initial dissection to be in the anterior plane and the second dissection to be in the posterior plane to prevent cap lenticular adhesion. So conventionally, surgeons use one half of the cap edge for delineation of the anterior plane and the other half of the posterior plane. But sometimes this happens in reverse and you tend to land up with trouble with cap lenticular adhesion. So voila, we have our technique which is novel and very safe, effective, very easy to adapt, the double anterior, single posterior delineation technique, and we also described a new release sign along with the technique. So in this technique, we propose that there are two areas of anterior lenticule dissection delineation which we do on both the sides of the cap side cut. Here also the maneuver of entering of the dissector is first sideways between the cap and lenticule edge, which is turned curvilinearly inwards towards the anterior plane to get to the anterior plane itself. So after opening the cap side cut, the dissector is entered in between the edges of the lenticule and the cap edge and turned curvilinearly inwards to automatically enter the anterior plane. The same process is repeated on the other side. Since the undersurface of the cap and the anterior lenticule surface are in line with each other, this maneuver ensures that you are doing anterior plane delineation only. When we do the posterior plane delineation, this is done in the central part, the central 1 mm area, and the dissector is entered straight in with slight posterior pressure on the cornea to reach the posterior plane. Now when we do the posterior plane delineation, if you have done anterior delineation correctly on both sides, you will find what is the double stop sign or resistance on both the edges. If you don't find resistance on one of the edges, that means that plane anterior delineation might be in the posterior part itself. After you have noticed the double stop sign, the double stop sign ensures basically that the overlapping areas between the anterior and the posterior plane that you have delineated are correct in all the three segments that you have done before. So this helps you in getting a second checkpoint in terms of that you are in the correct plane. And when we do the anterior plane dissection, you can start from any of the sides. As you move across to the undissected part and you reach the second already delineated part, there is a sudden release of resistance of the dissector that you can note. This gives you another confirmation that you are in the correct anterior plane only, and you will see here again that how there is a sudden release of resistance because that part was already delineated by you initially. So right here you see the sudden release of the resistance that you feel because you have already delineated that part before. Then the rest of the surgery is proceeded and completed in the usual manner by further completing the anterior dissection and the posterior dissection and taking out the lenticule. But when we do the posterior dissection, because you have only single area of posterior delineation that you have done, you will not notice any release sign here. So this ensures all the correct planes identification at multiple checkpoints. So as a novice surgeon with less than 5 cases of experience, when we did 60 eyes of 30 patients with a wide range of refractive errors, there was not a single case of lenticule misdissection or initial posterior plane dissection in our cases. The advantages of this simple technique is that it is very reproducible, easy to adapt even for beginners. Second, it is equally safe in low myopia patients because this is an area where most surgeons are hesitant because of having difficulty in lenticule dissection. Thirdly, it also gives an opportunity to rescue in case of initial posterior plane dissection because you are likely to have at least one area of anterior delineation still available to you to make an entry to the anterior plane. But the best part about our technique is the multiple checkpoints that it provides to the surgeon. First is the differential entry maneuver for the anterior and posterior plane delineation that we do. Second part is the double stop sign that you check. So this is the second checkpoint that you get, the surgeon gets. And the third checkpoint is when you are doing the anterior dissection and you see the release sign. So disadvantages are that, you know, it takes slightly longer time because you do anterior delineation twice. But, for a novel beginner surgeons, we would prefer a 3 mm cap side cut, but experienced surgeon can have even 2 mm. But rest assured, following this technique, every patient and the surgeon is going to walk out with a big smile from the OT undertaking any smile procedure.
Thank you. Actually, we still do one anterior and one posterior. I mean, we are amenable to anything. Did you see a distinct difference in all these eyes? You made you feel, no, I should be doing this step only and not the other one at all? Or would you feel, no, this technique, let me put aside for those lenticules which are very thin, where the dissection may be difficult, where the OBL is dense, where this might be one easier step. It need not be done in routine.
So when I started doing this technique, what made me adapt it for every case is that at the center, there are very experienced surgeons as well, but more often than not, once in a while, even an experienced surgeon was landing in initial posterior plane dissection. So that means that there is something wrong that we are doing that even experienced surgeons do land up. They are able to recover from it. They are able to reach the anterior plane, but that leads to a lot of dissection and, you know, stromal haze post-operatively that might take longer to recover. So using this technique, and you do this technique only for all keratolenticulaar extraction procedures, because I never land up with initial posterior plane dissection with this technique because of the multiple checkpoints that I get.
Suppose it works the other way. You have entered the posterior plane first, then
Right.
what?
So you will, first of all, do not get the release sign. So that is one thing. Second, that will only happen if your anterior delineation was also in the posterior plane.
Yeah, that's what I'm asking. You have anterior delineation. You haven't gone in the anterior plane at all. You have entered the posterior plane straight
So
away. As
so
your first
basically,
dissection.
to ensure that that doesn't happen, first of all, you are doing a curvilinear method of entry on both the sides, right? And when you are doing that anterior dissection, and if that would mean that you have all three, you have entered wrongly.
Yeah.
So that is highly unlikely to happen because the maneuver of entry is very different for the anterior plane and the posterior plane. But in that case also, what you will notice is that there will be no release sign, so that should click in your mind that I should stop and reassess whether I am in the right plane or not.
Okay. Thank you.